Good evening, everyone, and welcome to this webinar that's hosted by the Young ERC on debriefing after attending your first resuscitation attempt. My name's Adam Mellett-Smith. I'm the moderator this evening. I'm a paramedic from the UK and I'm a member of the Young ERC committee. We've had over 300 participants registered for this event, so we're really looking forward to a really interesting discussion. With us tonight, we have Carsten Lott, who's a medical doctor from Germany, and he's the ERC Director of Training and Education. He's joined by Aditi Nijwan, who's a resident doctor in anaesthesia in London, and is also a member of the Young ERC committee. We're going to hear their thoughts and experiences on this important topic. And as we go through, please do put any questions that you have for the speakers in the Q&A section of the Zoom, not in the chat box, please, in the Q&A box, so that we can collate them and then we can have a discussion towards the end of the webinar. Thank you very much. I'm going to hand over to Carsten, who's going to start.
Yes, thanks, Adam. Thanks, Aditi, for inviting me to talk about that very interesting and very important topic. You asked me first to talk about debriefing after attending your first resuscitation attempt. I thought this is simple. That's easy to do. So I still remember my first resuscitation attempt. So this is something you keep in your mind. And I think this is one of the reasons why that topic of debriefing is pretty important. But giving it some further thoughts, so I asked myself the question, has it been my first of all resuscitation? Should I talk about my first resuscitation as a team leader? Should I talk about my first toddler resuscitation? All that stuff. So a number of things come to your mind. And the most frustrating bit about that was at that stage, when I've been involved with my resuscitations, with my first all resuscitations, nobody has been talking about debriefing or things like that. And this clearly underlines for me the importance of debriefing in that specific cases. To get you started, I'm gonna give you a short case report, and then I will give you some background on debriefing. So we're gonna talk about the definition, the rationale. We're gonna talk about how to perform, how to do that debriefing. And then we're gonna look into potential problems that might come with debriefing. So the proposed case report. So I'm going to put you into an emergency department because I think this is a common setting where you can have your cardiac arrest and your resuscitation efforts. So it's in the morning. You're going to meet Mr. Cook. Mr. Cook is 65 years old. He's a male patient, and he's one of the patients we frequently see in our emergency departments. He's showing up for acute coronary syndrome. We received a structured handover by the ambulance team. So there was nothing really dramatic in that patient. There was no ST elevation in the pre-hospital ECG. Checking the patient, AB, fine. Looking to see there's some chest pain, but you already received aspirin, heparin, and some morphine. So he seemed to be fine. And looking into D and E, it was perfect, so nothing special. Standard procedures, so the patient was transferred to the monitor bed within the emergency department. And then I will put you into the role of the intern, who's part of the team in the emergency department. So you as an intern, you are sent to collect data of the patient, to draw bloods, and to get the 12-lead ECG you need to drive the further process. And while you're talking to Mr. Cook, who's already much better, suddenly he receives or he develops seizures. He starts gasping, and you immediately recognize, oh my God, this patient is going to get into cardiac arrest. You've never seen a cardiac arrest before. You're well trained. So you got your advanced life support training, you know how to handle a mannequin, but you never before handled a real life patient that's going to cardiac arrest. So further process, you start advanced life support. So you press your blue button, your red button, your yellow button, whatever you have in your emergency department. You activate the team shows up, and you start the full advanced life support process. Looking at a standard team you have in your emergency department, you have a senior doctor. This is your team lead. You have a junior doctor. This is the one who's taking care for the airway. Then you have nurses. One nurse is taking care for medication, for the timing. Another nurse is taking chest compressions, is starting chest compressions. And as you're the intern, most probably you will join on chest compressions. And then you have a paramedic on board, and the paramedic takes care for defibrillation in first place. So standard team setting, pretty well know, because you know that from the education programs you took before you started your career. Further on, the most probable reversible cause in that patient is coronary thrombosis. Nevertheless, you provide 40 minutes of advanced life support without any effect, and following that 40 minutes, your patient is declared dead. So your first resus in the emergency department, and the patient did not survive. So it's a hard way to learn that most of them are not going to survive, but this was your first ever case. What did you do during resuscitation? You provided chest compressions, but as the whole process went along for around about 40 minutes, you took over some additional roads when you've been in the pause between chest compressions. So you did some preparations of medication, prepared adrenaline amiodarone, and you tried to place an IV cannula, but you have not been successful on that. So what do you need now? So your first ever resuscitation, 65 years old man, acute coronary syndrome, felt better when you started managing him, and now he's dead. So what do you need? So what do you do in that case? I asked ChatGPT. What does ChatGPT recommend at that stage? So what do you as an intern need following an unsuccessful resuscitation? And this is what ChatGPT answered. So you need, and I think we all agree on that, you need emotional support and you need reflection. Then ChatGPT cites debriefing without further details. You need to have some documentation. Important as well to start communication with the patient's family if they are available. And then you want to have some kind of feedback. You want to have feedback from your supervisors, and you want to have that as a learning opportunity. And I think this is a pretty important part. You need to take care for your well-being, either yourself or you need external support for that. How to do that? And this gets us into debriefing. So if you look into the Oxford Learners Dictionary on debriefing, then this indicates that debriefing is an activity of asking somebody questions officially. So it needs to be an official task. You want to get information about a task you have just completed. Debriefing is usually done after a mission or a piece of work has been completed, and this is your case with Mr. Cook. Debriefing sessions are held to review the work that has been done, to identify what was done successfully and what was not. So this describes in parts what ChatGPT recommended earlier on, what you need to do now. Let's get further into debriefing, and let's look at the hot debriefing, or in some places it's called clinical debriefing. This is something you should do soon after clinical events. It is meant to involve all the frontline workers who took part in the patient care. You want to have some kind of reflection of the event that just happened. And the overall aim is to promote learning on one hand, but on the other hand, to benefit the staff and the ones who are involved well-being. And additionally, you want to identify opportunities for improvement you're going to go for your next resuscitation. The hot debriefing is meant to kind of create a supportive learning environment. You want to develop a shared understanding of the event that just has happened among the clinicians involved. So you need to clarify that the mental model is the same one for everybody, or that the other team members get a better understanding of your mental model, and vice versa. Yeah, you want to get an idea what their mental model has been. And you need to identify the need for further support, especially in that case where the patient has been declared dead in the end. So is there any need for an ongoing peer support? Eventually further on professional psychological support for the stuff that has been taken care for the patient. And a hot debriefing is meant as well for many people who want to express what they just experienced as to meet the need to talk about this stressful event they just experienced. So this is a little bit of background information. Next part is, how do you do that debriefing? What do you need to do? And there are three important steps in debriefing. This is the preparation, this is the performance, and this is the follow-up of your debriefing. So for preparation, you need to try to involve everybody that has been involved with the scenario, with the case you just worked. You need to allocate the facilitator for that. And that's, in my experience, a pretty complicated task, because you need to identify somebody who eventually has been involved with the case, but still is able to facilitate that talk, that debriefing process. I usually recommend to set the team leader, but this might be problematic due to hierarchic problems. Yeah. On the other hand, yeah, from what I learned when leading resuscitation teams, I always understood this to be a part of my responsibility as a team leader in advanced life support. And it's important to allocate a note taker, yeah, to take notes from what you're discussing later on. So how to perform a hot debriefing? Most important, you need to establish a psychological safe surrounding, yeah, and you need to apply that for the objectives and for the expectations as well. Usually you start your debriefing with a summary of the case, yeah. This mustn't be a full summary, yeah? So you shouldn't talk for 40 minutes, yeah, describing every single detail, yeah, that has happened during that resuscitation. Though you should provide a short, focused summary of the case, and it should be as neutral as possible. Because if you start at that stage to kind of value things, to get your opinion in, this might influence the further process of the debriefing. This is followed by a process where everybody is able to speak up. So you should actively try to involve everybody to bring up topics that have been relevant during the resuscitation. And then you should discuss all topics. I put relevant in breaks because you should focus on the important points. This is what I mean by relevant, but you should not miss things that are really important for a single member of the team, but eventually not relevant for the full team. There should at least be a short discussion on that. In the end of that, you should kind of come up with a list of things that went well and with opportunities where you can improve. In the end of the performance part of the debriefing, you should summarize the action points and the key learnings from the debriefing part. Also important, the follow-up part. So once the debriefing is done, you need to ensure that all action points are addressed later on. And you need to get an idea of a code debrief, so a debriefing process that is done with a little distance from the case. And you should ensure that this is provided, performed if needed. Potential problems. if you want to go for that kind of a debriefing process, you need to have a room. You need to find space where you can do that. So usually it makes no sense to start a debriefing in a crowded emergency department where everybody can listen to the group that is doing the debriefing and a lot of disturbing factors. It's the debriefing process. So you need to find a safe space where you can do that. And you need to have the time. You need to find time to take the team out to run through that debriefing process. And this kind of explains the need for a culture of psychological safety that is needed to have a standard debriefing process in situations like that. Yeah, then there might be interpersonal factors that might influence the debriefing and that very risk for a potential risk for conflicts, that should be avoided during that debriefing period. So in summary, uh, debriefings are important, and we know that frequent debriefings improve the team performance as well as the individual performance. We know from publications that there's a desire among clinical staff to debrief critical events. And for me, this is one of the most important parts of debriefings. Debriefings, besides giving you learning opportunities, benefit the staff's well-being, and this is something we need to take care of as well. So this is my introduction as far.
Thank you, Carsten. That was really interesting overview of debriefing. I'd encourage the audience to put any questions that they have in the Q&A box in Zoom, and we can come back to them. But whilst they do that, Aditi, would you like to talk about your experience of debriefing your first cardiac arrest?
Sure. Firstly, thank you very much, Carsten. That was very interesting and very helpful to put into context about what I'm about to speak about. So just to give you a little bit of context for my first resuscitation attempt, I was a fourth year medical student. This was about 7 years ago, and I was volunteering with my local ambulance service as an emergency responder. I'd been volunteering about 2 months, so fairly inexperienced, didn't have very much clinical experience, but I'd been trained in BLS countless number of times. We were responding on a fairly average summer sunny day in London, where we get a category 1 call, which came to our radios as ineffective breathing. Now that can mean a number of things, but generally it means a very sick patient. So as we were driving to this call, I had a number of thoughts going through my head. I had a lot of nerves. I'd never been to a cardiac arrest before. I'd never been to an extremely sick patient before. I had worries. Am I going to freeze? Do I remember what to do? Do I remember how to confirm cardiac arrest? How will I react? All of these kind of fairly anxiety-provoking thoughts going through my head. So we arrived on scene shortly after. It was a 70-odd-year-old man who was in cardiac arrest, and we were first on scene. Straight away kind of got into the almost autopilot mode of this is what we learn, check for cardiac arrest, CPR, AED, and bag valve masking him. After about 5 minutes, more crew members came. We spent maybe about half an hour, 45 minutes undertaking a resuscitation, like Carsten described in his ideal team resuscitation. And we managed to get a return of spontaneous circulation after about 45 minutes. This patient was then taken to hospital. And I guess that my key thoughts, I'm not going to focus too much on the case itself. It is fairly similar to a lot of the cases that people would have experienced in cardiac arrest. But the subsequent debriefing type events that happened definitely changed the way that I look at my resuscitation attempts now. And it's definitely has turned what could have been or potentially was at the time quite a traumatic, anxiety-provoking experience into a very productive learning one. So the way the debriefs worked after my initial resuscitation attempt is something I think those of you that work in the pre-hospital setting, EMTs, paramedics, that hospital clinicians don't benefit from is you're able to ask if emergencies permitting, ask to be booked off emergencies for a period of time, sometimes 10, 15 minutes, while the immediate team carries out a hot debrief, which is what we did. So we all got together at the back of an ambulance, opened the floor to the team leader, who was able to describe the event succinctly, followed by kind of a round robin around whoever had what thoughts, what concerns were. And I think for me, that was my first ever cardiac arrest that I'd been to. And that was really quite helpful on multiple counts. One, from a feedback point of view, to be told actually your CPR was effective. You did manage to confirm cardiac arrest. What felt like long delays in your head was actually a couple of seconds. So just positive reassurance and feedback to a very anxious new clinician can be extremely valuable output from debriefing. I think another benefit of a hot debrief for young clinicians is the ability to actually appreciate the whole resuscitation from a bird's eye view. So I think I definitely still feel sometimes when you get allocated a task such as CPR or airway, you do get quite task focused. And I think that's a very completely normal thing to happen. And actually, particularly when you're quite junior, you kind of lose sight of where the whole arrest is at, how many cycles we've had, whether we've given shocks, whether we haven't. Like in Carson's case, who made the decision to stop and why those decisions were made. You often don't really appreciate that during the arrest time, particularly when you're feeling quite maxed out with the task you have. And so I think a debrief is a really valuable way of you trying to understand the whole kind of arrest and everyone to understand each other's point of view that may not have been able to be appreciated at the time. Following this, I obviously did think about this resuscitation for a while. It played on my head again. Was the CPR effective enough? Did we respond quick enough? Lots of things, even just the fact of seeing someone in cardiac arrest for the first time, and it does play on your mind. It was on my mind for a few days. And I think what really sealed the deal in terms of changing my view on looking at resuscitation attempts as a learning outcome was a cold debrief I had with one of my supervisors a few days later, who just sat me down and again, one-to-one, just spoke to me very candidly as though a friend would, asking me, this was your first resuscitation experience. How did it go for you? Describe the case. What are your thoughts? And they really signposted to me that, it's normal to feel the thoughts that you might feel after your first resuscitation. It is quite an overwhelming thing to do, to experience. And just saying that that's very normal, we've all had it before, was very reassuring and kind of helped me take away some positive points, helped me come away from the whole resuscitation thinking, actually, we did a good job, regardless of what the outcome might or might not be in hospital. This is something that I can work on as an educational opportunity, work on trying to make my own skills quite slick, and come away with an overall experience of learning rather than of dread for the next cardiac arrest. And kind of just to finish off, I think 8 years on, I'm now training in anesthesia. I've been to countless more cardiac arrest resuscitation attempts, but I think debriefing is as valuable to me now as it was in my first arrest. I recently had a particularly tough resuscitation in the operating theatre with a traumatic cardiac arrest. And while I'd been to countless arrests before, this was my first in a patient with traumatic injuries and my first in an operating theatre. And it was middle of the night, short-staffed. Overall, a poor outcome. The patient didn't survive. And I remember for the whole hour and a half long resuscitation we carried out, I had a lot of frustrations about aspects of the overall resuscitation. I had a lot of anxieties about, again, are we doing this right? Are we drawing drugs up fast enough? Have we given the right things? And I really left that resuscitation feeling very on edge about the whole experience, the whole process. And it was actually one of my senior registrars that asked to do a hot debrief about an hour and a half later, where all the clinical team came back to the theatre and once again just ran through the case, talked through everyone's anxieties, everyone's worries. And actually, what gave me a lot of reassurance was a lot of the frustrations that I had, and I thought maybe I'm just not experienced enough to be okay with these things, were the same frustrations that the consultant trauma surgeon had, that the anesthetic consultant had, that all of the experienced scrub staff had. And actually just everyone voicing that experience definitely, once again, turned that fairly traumatic experience into one where I took away learning. And my next night shift, I came back, I wasn't dreading having another arrest. In fact, I was thinking what I took away from that was, what would I do better next time? That was the overarching learning. And so I guess for anyone here that's working in clinical teams, however junior or senior you are, I guarantee you, if you want a debrief after resuscitation, you are not the only person that wants that debrief. And I would like to hope and encourage young clinicians to just feel empowered to ask for a debrief, because I'm definitely, if you ask, there's other people wondering the same thing. Like Carson said, often it would be nice if it's the team leader that leads the debrief, but often the team leader might be so experienced, might not realize that the team actually needs a debrief, and therefore it doesn't have to necessarily be the most senior person in the team. There are tools that you can use to guide a debrief, but actually at the end of the day, what everyone needs is just a chat which has the rough structure of what Carson said. So I would definitely encourage anyone to just, ask the question. You don't have to lead it, just ask, can we have a debrief? And trust me, you will feel a lot better. You'll feel like you've learned, and you'll start to look at resuscitations in a positive learning light.
Yeah, very important. Thanks for that. What I would like to reinforce on what you just said. So I do not agree that team leader can be too senior. To not to do debriefings. Let me call it that way. So this is what I meant by. For me, this is kind of a responsibility of a team leader. Team leader, in my opinion, needs to direct the team during the resuscitation process. But from what I learned and from what we actively teach in our ESC Advanced Life Support courses, the team leader is responsible for the team following resuscitation as well. And so for me, the ideal person, because in many times this is the most senior person in the whole process. So for me, the one who's ideal in facilitating the debriefing. And this is something we need to learn as well.
No, I definitely agree. I think the team leader generally has the oversight of the whole resuscitation. They're the ones that have seen it normally from start to finish. And often, like you said, what we teach in courses, what we learn in courses is to be that leader from start to finish, including afterwards. And sometimes just ask, if it's not happening, you can ask the team leader, do you mind leading a debrief? They might have just slipped off their mind if they don't plan to do it. But ideally, we should all become team leaders that are leaders before as well as after the resuscitation. Completely agree.
Yeah, sure. So it should be part of our culture. So if we can talk about resuscitation culture, debriefing initiated by the one who's leading the team should be standard of care. So it should be a cultural thing, no doubt about that. But it needs a lot of experience as well. So this is what I always notice when running courses or when doing this in real life. When you ask the team leader to start the briefing, and this is one of the problems in setting the team leader as the lead for the debriefing. Many times they are still focused on what they've just done and they want to get clarification for problems they experienced during the process. And this is one of the complicated parts in doing that facilitation. In the end, you need to step out of your own body at that stage and really try to get an overarching perspective to describe the case in a very neutral way and step in later, giving others the problems you experienced during the whole process. This is, in my opinion, pretty complicated.
No, definitely. And I think there's a contrast between different settings, and I guess we have people listening from all over the world. There might be different structures within your hospital. I definitely feel in the hospital experience I've had, sometimes you feel like there's not enough time to do a debrief after a resuscitation attempt because there's 10 patients waiting in A&E, 20 waiting on the wards to be seen. But I do think it's so valuable, even if you just take 10 minutes to start that debrief, barring a massive clinical emergency. Otherwise, I think there's always a possibility to create time. And I think sometimes we just have to that's again, a good leader's responsibility to try and just carve that time to make sure that there is a debrief that's done.
Yeah, fully agree on that. And this is not only the learning opportunity, so this is getting us back into the well-being part as well. I think this is an important bit. We need to take care for staff, for everybody who's involved. And this can only be done if you establish a culture like that, because then people tend to stay where they are. This is what they need to be able to act as they do and to do their daily job as they want to do it. They need to get the feeling that others are taking care for them as well, and it's not only them taking care for the patients.
Thank you. Thank you both. So there's some interesting questions starting to come through, but just picking up on that point that you've both just raised there, and it came up in your talks. So how do you combat that where you're in a busy department and there are lots of other patients around? How do you carve out the time to make sure that a debrief can happen? Because it's really clear from both of what you've presented how important it is.
So I'm happy to start on that one. I think I have definitely been in that situation. In fact, most of my in-hospital resuscitations when I was kind of starting out as a doctor were we didn't feel like we had time to debrief, and I often felt like I really wanted one, but I didn't feel like I could ask because there was so much pressures. I think as I've kind of gone through the years, I've realized there's always pressures in a hospital in a busy department. And those pressures will continue to be there whether or not there's resuscitations. And I think, whether it's a good outcome, particularly if it's a bad outcome, just even to allow people to be able to mentally get back to work from a well-being point of view, I think it's something that you just have to carve out time for. Like, it doesn't need to be long. Like Carsten said, no one's asking for a 40-minute, run through the case. Even just a 10-minute, 5-minute check-in with some tea in a corner, in a little room, just having that conversation, checking in, making sure people are okay to go back to then see their next back pain, chest pain. I think, the pressures will always be there, but this is important, I think. And the only way I think it's worth investing that time, because the pressures will never go, but the pressures will be a lot more manageable if you've got a workforce and a staff that are able to do their best, able to be mentally in the right place to carry out and managing the rest of the department.
Yeah, adding to that, I think there are two keywords describing what you need to do, how you can do that best. But first of all, the 10 patients are always waiting, independent from what you're doing. They're always there and they're always waiting for you, and this will never stop. Keywords that are important. Number one, this is what I mentioned several times before, this is culture. This needs to be part of your culture. And as soon as it's part of your culture, then everybody's used to that. Nobody's wondering if you start doing that debriefing process, because this is part of the patient management. And the other one is trigger. Yeah, so this is part of a system for debriefings. Yeah, you need to define triggers when to do debriefing. Yeah, and this can be part of your culture. So if one of that triggers if you get to one of these triggers, yeah, then you need to do the debriefing. That is totally clear to everybody. Yeah. So you can set a trigger at the stage you say a patient dies despite all your team efforts. Yeah, this is a clear trigger, and here you need to do debriefing. Yeah, there's no way around that. And if this is clearly defined and transparent for everybody, yeah, then you have the time to do so.
Great, thank you. That's really helpful. So Carsten, you said at the beginning of your presentation that you remembered your first resuscitation. I think most people listening who've attended a resuscitation will also remember theirs. One of the questions that's come in is about your first resuscitation and whether you experienced this sort of debriefing earlier on in your career, or whether you've seen changes in how that's happened over your career.
Yeah, so for me, this was a horrible event. So it was close to getting me out of medicine. Yeah, to be really honest about that. It was a traumatic cardiac arrest. It was a traffic accident, and we had 3 people dead, and management was not optimum. And we went to hospital with the patient and an ongoing resuscitation. He was dead in the end, and then nobody talked about that. This was horrible. So this was totally clear to me that this is not the way to move forward. This is not the way how you can teach people. But this was in the early 80s, and nobody thought about things like debriefing. So this was, we worked, and then this was it. It was done, and we moved on. That was all we did.
Gosh, it sounds like a really difficult event. And so have you seen debriefing sort of develop over the course of your career? Have the strategies that you use changed? And are there strategies that you would sort of advise that people use or avoid that you've seen through your time?
Ah, yeah, so yeah, I'm an old beggar. Yeah, so no question about that. Yeah, so you all know that medicine has dramatically changed within the past, let's say, 10 to 20 years. Yeah, so medicine was pretty hierarchic. I think this was pretty hierarchic in the UK as well. 30 years ago. This is the time when I started, even earlier when I started my career in medicine. Yeah, so you had to perform or you've been out. Yeah, so this was a standard. So nobody thought about well-being or about debriefing or things like that. Yeah. And this is something we learned. Yeah. We learned from experience. We learned that patient care improved. Yeah, if you started talking about things. Yeah, if you started to have a common learning goal. So not only doing mistakes and getting told you're gonna this was wrong, but nobody explained to you how to do it better. And this is something that has changed. So it gets me back into the term of culture. So culture has changed. And we have learned that if we start talking about problems and if we have an open and transparent exchange on that, we can get much better than we can do if we only practice, 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 do mistakes, and do not really improve the way we would be able to improve. Additionally, we started implementing debriefing as standard procedures in our teaching, and I think this was one of the game changers. So when we started doing simulations, and when we started thinking about how to improve the learning outcomes coming from simulation. This was the first step when we found out that if we do that kind of talking to people about what they did, identifying problems, but putting them in a safe space. We noticed, and there's a lot of publications on that learning outcomes massively improved. And yeah, next stage was transferring that into daily practice, starting doing the debriefings in daily practice to have that effect, that learning effect, that education effect from debriefings in daily practice as well. So I think there's a lot that has changed over the past 30 years.
Thank you for that. And that leads on really nicely to one of the other questions that's come in actually about the difference between a clinical debrief and a learning conversation or a debrief that you might have in a training setting. Do either of you have any thoughts on that?
I think that's an interesting question. I assume the learning conversation they're referring to is something that we often do in our resuscitation courses, such as ALS. So at the end of a simulation or a learning experience, the facilitator will open the floor to particularly the leader asking how they felt, and then have thoughts from the group and the participants, and have that kind of learning conversation. I think how a clinical debrief is different. I think fundamentally, I mean, the idea is trying to gain everyone's thoughts and learning, and that is very similar. And part of, based on what Carsten was saying, the learning conversation has been integrated into these things, hopefully to try and also help the people then going to practice these courses in real life to take on that debriefing angle and take on leading those debriefs. I think they are obviously different because one is a learning conversation and a simulation. Good or bad outcome, it's still no one's died, it's not a real patient. Whereas your actual kind of clinical debriefs may invoke a lot more emotion, a lot more kind of frustrations. But I think the kind of underlying principle of why we do the learning conversation and why we do a clinical debrief is fairly similar. Carsten, I would love to know your thoughts.
Yes, so fully agree on that. So structure-wise, it is comparable. Major difference for me, and this is something where I'm playing around a bit at the moment in courses we do in education programs. Usually, learning conversation has a facilitator, has an external facilitator. And this is in most cases different in the clinical debriefing, because clinical debriefing comes out of the group. And if you're playing around in your courses, and if you start the learning, if you manage to get the group used to the learning conversation in a way that they can run it themselves, then you get pretty close to a redebriefing, because at that stage, they start thinking about what they did, and you do not need to get them keywords to get into the full process. They need to think about their keywords themselves, and this is when they start recalling their own actions, their own activities. And in my opinion, this further improves involvement in the whole simulation process.
Just to add, actually, so your question about the learning conversation has made me think of something that I think my department does very well. It doesn't quite fit the idea of debriefing in that it's not a hot debrief, nor is it run by the clinicians that were involved in XYZ case. But what we do have is kind of every couple of weeks, one of the senior consultants will have kind of just a semicircle of chairs, some coffee, and have some protected time with the junior residents. And it's very, very much an open floor to bring any difficult cases that may have not had a chance to kind of be processed, be properly debriefed. And they do run it very much as a learning conversation. It's facilitated essentially by an external facilitator, one of the consultants that wasn't there at the case, but it allows us to draw learnings from what can be often quite challenging cases, somewhat between a learning conversation and a cold debrief as such. And that's definitely something I've taken a lot of cases to and found very valuable. And like I said, not formally a debrief, a resuscitation debrief as such, but it's something worth thinking about for anyone working in particularly tough environments where you feel like you might not have the opportunity to debrief as much as you want to.
That perfectly adds to the culture again. So this is something I used to do as well when working with theaters. So was we called it something like end of the week discussion or something like that. So it was usually on Friday mornings, on Friday afternoons, and we took that semi-half circle and we discussed cases, we discussed events that happened during the week. And we wanted to present to the others. We wanted to discuss. We wanted to have answers for questions we didn't ask as far. So something that in between the cold debrief and the hot debrief. But it's important and it has a great learning effect. I fully agree on that.
Brilliant, thank you. That's really interesting. Just moving on slightly then. So, Aditi, in your presentation, you mentioned two debriefs, one that happened on the back of the ambulance and one that happened in a theatre where you all came back together. And one of the questions that's come through is around where you should do the debrief. Should it be in a clinical environment or should it be somewhere protected? I think, Carson, you mentioned having a room available. What are your thoughts on where the debrief should take place?
Interesting question, actually. Not necessarily something I've thought very much about location. Just trying to think practically. I think, like Carson said, I think having somewhere enclosed and private is really important. And I think it very much depends on what kind of setting you're working in. That might not be a very, like a room with a lot of space. It might be your like main resting area has lots of other stuff, and if you want it to be a private area, for us it was theatre, and maybe that's not necessarily the right place to have it given we just had all of these events there, or maybe it is because it kind of puts you in the same scene and you were able to kind of come full circle and close that chapter. I'm not sure what I think wherever it is, personally, I feel like it just needs to be private and enough space, quiet, where you can hear everyone. And that might be the back of an ambulance, it might be theatre, it might be a coffee room if you've got one.
Yeah, fully agree on that. Yes. So if you go for the clinical that hot debrief, you usually do not have sufficient time to identify a room where you can do that. That is really comfortable for that kind of discussion. So most of the cases I did are in the back of an ambulance. So I need to make sure that there's not too many disturbances.
Thank you. And along a similar vein, a couple of the questions are about when to do the debrief. So you talked about hot versus cold debrief. There's a question in here about when what's the timing for a hot debrief, but also when is it too late to debrief? Is it ever too late to do a debrief? Do you have any thoughts on that?
It can be too late, yeah, no doubt about that. Yeah, and this is, I've been talking about responsibility earlier on. Yeah, this is something you to need to try to keep in your hands when you've really done a complicated case. Because once people are gone and they take their problems with you and you didn't notice, then this might really be complicated. And this is something I experienced 2 or 3 times. This is really hard to get back to them, to get hold of them, and to start the debriefing. Yeah, but sometimes this really might end in the need of some psychological treatment for the persons. Yeah, so. In my opinion, the hot debriefing should take place as soon as possible following the handover of your patient. Uh, so you need to try to assemble everybody. Don't let them get out. Yes, they can have a cigarette or something like that. 5 to 10 minutes. But at that stage, you should be finished and should assemble them and start the debriefing.
I think from a cold debrief point of view, um, some cases may not require a cold debrief. I think that's very much, it's probably worth having a chat at a hot debrief and thinking, is this something that needs looking into further? Do we need to rearrange a cold debrief? Often quite big, fairly traumatic cases do end up getting a cold debrief, particularly if that clinical outcome is something that's not expected. And I've had a cold debrief for multiple cases, sometimes like a month and a half after, because there's been lots of investigations and it's been run kind of as a let everyone cool off, let's run through all the events in exact order so that there's maximum learning for everybody. And I've actually found that extremely helpful with kind of a tough maternity case in the past. So to answer your question, I don't think I don't think it's too late. I think if a cold debrief is required, obviously, if you do it years later, people are unlikely to remember the details. But I think in the weeks to months after, sometimes that's the most appropriate time where you can find people available, the investigations done in space. So I think that might be the only time that it's possible.
Great, thank you. So a few of the questions that have come in are all along similar lines. So I'm just sort of going to summarize the questions into one. So more and more we're seeing lay responders becoming involved in resuscitations, and sometimes they are people who know the patient directly. So how would you or wouldn't you, and then how would you involve lay responders and people who may know the patient in a debrief?
So, okay, if I can start on that, yeah, you need to involve the responders if they know the person. Yeah, we just did the resuscitation, and in my opinion, it is pretty helpful. And we are starting a big project with lay responders in the region where I'm working at the moment. It is really helpful to have a debriefing together for the whole team that has been involved. Because then they kind of notice, they recognize that they have been part of a bigger team, and that they really have contributed to either the success of the whole resuscitation, or that they have done their best, but that the person they know has died, but that they tried to help, and that has been the best they could give that person they know. Yeah, so can you solve it in most of the cases? And if you can't, yeah, then you should have structure in the background, and this is something we have available that can take care for that lay person further on.
Thanks, Aditi. Do you have any thoughts on that?
That I found quite an interesting question. I don't think I've actually been involved in any resuscitations that have had a um close mem. I guess with pre-hospital, yes, definitely I've been involved with cardiac arrests where family members have been involved, but they weren't part of the debrief. And actually, your questions made me think maybe they should be a part of the debrief. And I know that we often have signposting within the ambulance service where we give a kind of contact number to family members that have been involved in resuscitation, and they get contacted by an independent person to check in, but they don't necessarily get to be a part of the team despite them having started the resuscitation. So that's interesting food for thought for me. Thank you.
Yeah, it is interesting, and I think there's obviously logistical challenges around it, aren't there? Around how you involve these lay responders in a clinical debrief. If the patient's gone to hospital, maybe they won't be involved in the clinical debrief. But it's important to think about other ways that we can support them for sure.
So we have a big advantage in our system in Germany, because we have a two-tiered system. Yeah, so if the ambulance goes to hospital, the patient, the MICU still stays in place, and then I have at least one paramedic who's able to have a short debrief with the relative who started any activities. And this is what we usually do. These are the ones who start taking care for that relative, and they eventually arrange for future care for them.
That's really interesting. Thank you for sharing that. And that's certainly that in my experience in the UK is that in a resuscitation, all of the ambulance clinicians go with the patient to hospital, and we sort of just leave the family at the home often. So it's really interesting to think about that. A couple of other questions. Do put some more questions in if people have them. We've got about 6 or 7 more minutes. But the remaining questions are around how you structure a debrief. So, Carsten, you talked about some of the things that you'd include in a debrief and some of the important considerations. But a couple of people have mentioned some debrief tools, some structures, some mnemonics that they are aware of. Is that something either of you have experience with, or would you recommend using that if people are not used to running debriefs?
So I've gone through them this afternoon, yeah, to get an idea what's on the market at the moment, yeah, and most of them are the same, yeah. So they are all describing the same principles, yeah. So in my opinion, most important part, and this is what we see and what we learn from our educational programs, is to train. Yeah, so you can use either mnemonic you want, yeah, as long as they cover the important parts. But none of them makes any sense if you do not practice. And if you practice them, then you will achieve a stage at one time, yeah, where you are able to do it without a mnemonic. Yeah, so they are always helpful to visualize, to memorize what you want to do. Yeah, but they will never replace an adequate training.
Yes, I also looked up various toolkits to see, what is there any specific National Resuscitation Council recommendations? Is there ERC specific toolkits? And I think I came to the same conclusion that most mnemonics toolkits, I think they're a very helpful way of, particularly if you're someone that's new to running debriefs and recently stepped up as a senior doctor, recently started leading resuscitations. I think it's a helpful tool if that helps you structure it. Similarly, at the end of the day, whichever way you're covering, prompting these questions, having this conversation is fine. Whatever works for you, as long as the right conversation's being had one way or another.
Yeah, but adding to that, yes, so the main problem I always find if we have some education programs on debriefing is to control the emotional part. And this is hard for most people, and this is nothing you can cover with any mnemonic. You need to really make clear that you, as a facilitator, need to step back. And you step back and start the debriefing process. To leave it open. Yeah, otherwise you are the one who's setting the bias, and then everybody is following what you're saying, and this is not going to get you into a real debrief. Yeah, so it's pretty important to start without any emotion, to start as neutral as possible, and this is something you need to practice. This does not work without practice.
Right, thank you both. I think so. Currently, we've covered the questions that have come through. So I just wondered if either of you have any sort of final thoughts to round up this conversation. It's been a really interesting conversation to listen to.
Yeah, so this is up to you as I started.
I guess I just want to say thank you, firstly, Carsten, for all of your thoughts and kind of putting the concept of debriefing into kind of formal a formal lecture. I think that I've learned a lot from just seeing it structured out like that. So that was really helpful. And I'd also just like to say thank you to everyone for all your questions. I think it's definitely given me a lot of food for thought when it comes to debriefs. And I'd just like to reiterate really what I was saying before about, I cannot understate how important debriefing is, and how it's often going to feel like you don't have the time, but it's so, so important. So just, you know, if it's not something that's happening regularly in your department, just ask the question, use a prompt, feel free to, speak to someone who you're able to have that conversation with, who's a senior member. It is very much about the culture. And once you start asking the question, other people will as well. And eventually it will become established within your department, the culture of debriefing, which is extremely valuable.
Thank you very much, Aditi. And thank you both of you for sharing your thoughts and your experience. It's been a really useful conversation this evening. And again, I'll just echo what you've said, Aditi. Thank you to all the participants who've given some really well thought out questions that have made us all think, I think. So I hope people have found this webinar useful. We will draw it to a close here. So I'd like to thank everyone for joining. Again, thank you to Aditi and Carsten. Just to close, we'd just like to draw everyone's attention to the fact that the call for applications for the Young ERC Resuscitation Science Masterclass, the third edition, is now open. We've just put the link on the screen, so if you scan that QR code, you'll find lots more information about the programme. This is the third time that we've been running this masterclass, and it's received brilliant feedback on the last two. So I'd really encourage people, if you're interested in resuscitation, to have a look at the link and consider applying for it. Thank you, everyone, and have a good evening.
Have a nice evening. Bye.
Thank you.